We'll move on to the next speaker, who's Danjuma Adda, who's from Nigeria and is the president of the World Hepatitis Alliance, the first African to hold that position. And he's going to talk about, can integration reduce stigma, lessons learned from HIV.
Thank you. And I would like to say thank you to COLDA for having me on stage, and thanks for inviting me. So Philippa has done a lot of justice to part of what I'm going to speak about, but I would like to say that I come from a background of public health and then also some little bit of HIV. And where I come from in my country, my state actually in Taraba State, on the gold medal chart, we are top there on HIV, and we're also top there on hepatitis in terms of prevalence. So before assuming the role of the president, I also work in the space of HIV and AIDS. So can integration reduce stigma? My answer is yes and no. Now, coming from the background of HIV and then hepatitis now, we have this issue of siblings, rivalry in my state, and where we have this family, we have these 3, 4, 5 siblings, and they keep competing for the attention of the dad, keep competing for resources, and we have this one big boy that will always marshal the other ones and would always seem to grow bigger than the other ones, and that is exactly how the HIV and hepatitis response is. So the HIV is like the big boy in the room that always gets the Gucci branded clothing, that always get all the branded clothes, but hepatitis is down there, always at the back. See the boy that right there. So in the hepatitis space, we're not asking for Gucci brands. We're just saying we want to share the resources of our siblings, and which is not always available. So the Global Health Sector Strategy 2022 to 2030 builds the framework of integration on people-centered approach. And it promotes putting people at the center of national responses in the context of universal health coverage of leaving no one behind. And it also talks about delivery of services should be people-centered and tailored to diverse populations and settings, reducing inequality. So why is this really important, that is integration using the people-centered approach? This is because hepatitis B and hepatitis C and sexually transmitted infections, that includes HIV, share the same modes of transmission. We mentioned their siblings, right? And co-infections are common, meaning people at risk of acquiring one infection will often also be at risk of catching one of the other infections. Now, before we talk about integration, it's important to understand the diversity of hepatitis. And hepatitis B and C impacts men, women, children, adolescents differently across the world. And can we say that the number diagnosed with hepatitis B and C are representative of the undiagnosed? Certainly no. The prevalence and the estimates we have now is just the tip of the iceberg of the reality in terms of diversity. Now, why do we need to understand this diversity? Programs should have the diversity of people living hepatitis in mind in developing interventions, strategies, diagnosis and goals, including guidelines. Guidelines and diagnostic platforms should have the context of regions, should the context of populations, so as to serve the needs of the people. Remember, we're talking about people-centered approach. And it's good to know that the current WHO, especially HCV guidelines, really speaks to the context in Africa. So disparities also exist with testing for hepatitis B and C infection among racial, ethnic minorities. There are disparities on testing, disparities on vaccination, and even on access to treatment. Now, there are a lot of prerequisites for integration of hepatitis into other healthcare services. Number one, programs should understand priority populations, which might include people exposed to sexual transmission, including young people and adolescents, men who have sex with men, sex workers, transgender people, prisoners or incarcerated population, people with multiple sex partners, and people whose sex risk taking is mediated by drug or alcohol use, people exposed to unsafe blood supplies on unsafe medical injections and procedures, people who inject and use drugs, young people, including young key populations, children exposed to vertical transmission or early childhood infection, pregnant women, women and girls who may be vulnerable and at risk, including as a result of gender inequalities, young people, including young key populations. So it's very important for all programs to really have the context of populations before you talk about integration. So that's to provide people-centered approach. Now, there are a lot of opportunities for integration of services, just like Philippa mentioned earlier. And one is the maternal and child health, where you could look at integrating hepatitis B PMTCT and the hepatitis B birth dose vaccines. And also into liver cancer, we know that hepatitis B is the leading cause of liver cancer. So hepatitis B vaccination is a cancer prevention vaccine. And hepatitis B testing and linkage to care could also prevent liver cancer. And integration also into sexual reproductive health and STIs, when it comes to adolescent catch-up vaccines, youth-friendly services, in harm reduction, infection prevention and control. I will also add in even antimicrobial stewardship. Hepatitis B vaccination could be an antimicrobial stewardship. A lot of opportunities to integrate hepatitis into other healthcare services. A non-communicable disease as well. And of course, HIV, TB services diagnosis systems, like Philippa mentioned earlier, where we could have using multiple diagnostic platforms to diagnose hepatitis B, DNA, and HCV RNA. But stigma reduction can be achieved if only healthcare professionals are trained to provide stigma-free hepatitis services. I remember so many years back, just out of school, I got involved in the clinical settings in my states in HIV supporting diagnosis, the viral loads, and all the stuff related to HIV. So on this clinic day, and in those days, of course, they have designated days where people go for HIV, CD4 counts. So on those days, almost everybody you see there attempt to be people living HIV. So I saw these folks sitting down, about 3, 4, 5 people waiting on the queue to get their samples collected, and I walked up to them. I saw the first guy sitting. I was like, how are you feeling now? How is your body? How is your health? So the guy looked at me and said, I'm not sick. I'm just living with a virus. So the language of healthcare providers in providing services could drive stigma. And like they used to say, what happens in Vegas, you remain in Vegas. You see people in the clinic, and a lot of healthcare workers will have that as topic of discussions with neighbors and families and spouses and partners, and this drives stigma. So healthcare providers should provide stigma-free services, which will go a long way to help in integration. And integrate hepatitis into universal health coverage packages. But countries and programs should understand what are the minimum UHC packages they have to offer. And simplifying and decentralizing service delivery to primary healthcare services. Unfortunately, across Africa, most of the hepatitis services are provided in urban centralized laboratories because majority of the primary and secondary facilities don't have diagnostic platforms for hepatitis. So, but then, for us to really break stigmatization, we need to get service to primary levels of care. GPs in secondary and primary levels of care should have the competence and skills to look at patients, to look at people and manage patients. So that we need to have, so people could just walk into the primary center to access care. They don't need to go to the urban centralized places in order to have care. So decentralization to primary levels of care could be one way to reduce stigma in integration of services. And then integrating services to multiple disease as a key element of people-centered health services at all levels of care, providing multiple tests, like Philippa said, one-stop kind of services, and simplification of treatment guidelines to increase uptake of care and reduce multiple hospital visits. One of the challenges we have, especially in hepatitis B treatment, is, for example, we're still using the 2015 guidelines for hepatitis B. And one of to initiate a treatment, the guideline says you must have viral load of 200,000 and also elevated repeated liver enzymes. The patient will not come. Some patients travel 5 hours, 10 hours to hospital facilities, and you want the person to come back. And remember, most patients pay out of pocket. So guidelines should be simplified, and I hope WHO is doing that. So to be simplified so that we have reduced multiple hospital visits, which are real turnout issues that drives patients away, and people will never come back to access care. Now, stigma can be reduced if integration efforts do not have unintended negative consequences, and that progress achieved by disease-specific responses is sustained, in particular for the most affected and at-risk populations. Now, the second point there is where I have a lot of issues, and mono-infected hepatitis B or hepatitis C persons might have challenges accessing services in HIV clinics. So if hepatitis care is integrated in HIV clinics, the mono-infected person will not go there. I live with hepatitis B. I don't want to go to the HIV clinic to access care because obviously the community and everybody thinks the stigma issue. So hepatitis integration of services should not just run in. For mono-infected patients, it becomes challenging to access care in HIV clinics. So then also programs and interventions and clinics should be rebranded to reduce stigma in care. I remember all those years, there is always that HIV clinic and designated days for viral load samples, CD4 count samples, and then the centralized laboratories. People running HIV screening will wear the clothing, they have HIV test and counselor, and that drives stigma. And what my small charity does in Taraba is that we rebrand our activities and outreaches so as to make it look sexy, right? And attract people. They don't feel stigmatized. We do blood sugar testing, we do blood pressure monitoring, and when those people come, we're like, do you want to do HIV testing? And we've been able to identify a lot of people living HIV who are undiagnosed. Rebranding. So HIV clinics, interventions could maybe rebrand so as to attract more people and reduce stigma. Medical terminologies and terms should be simplified. For example, you go to an average hospital and you see the doctor, they tell you, hepatitis B is complex and difficult. And this is a patient having trauma, is challenging, and then you're telling him hepatitis is complex, and he's looking for hope. He goes out to the hospital, and you tell him it's difficult, I don't know. So where else does he find hope? Where else does he find solution to his problem? Just outside the hospital, he meets the quack who tells him, hepatitis is simple. Don't eat meat, don't eat fish, I'm going to cure you of hepatitis, right? And he falls for it. He goes for it. That's a simple word he wants to go for. So, medical terminologies and terms, please don't confuse a patient with medical terminologies. That also helps in reducing stigma and improving uptake to care. Now, look, this is just an example of our branding of activities. We do blood pressure monitoring, and then we put it at NCDs, we put it as health interventions, and that really helps to improve uptake in care. Now, lessons learned from HIV, strong networking, and network platforms to reduce stigma through peer-to-peer support and peer linkages. Indeed, that has really helped to really advance the cause of HIV and advocacy. And even at the World Hepatitis Alliance, that is what we're also doing. We build a community engagement, we build the voice of our members, and we try to build networking platforms for our members to be able to amplify and to amplify the awareness on hepatitis. So empowering communities to take responsibility over their health is also one key lesson learned from HIV, and differentiated models of care, taking healthcare to the people. People don't need to move, and then using the family-centered approach, using the people-centered approach has indeed helped to reduce stigma and break the multiple systems challenges in hospitals and also in improving uptake to care. Like I said, there's a lot of disparity in HIV and also hepatitis. So you have diagnostic platforms that cannot work without electricity. That's not going to work in most African countries. You have diagnostic platforms that cannot, because a lot of times we travel long distances just to provide care for people. So thank you so much, and I hope that you enjoy the rest of the day. Thank you.